afternoon and welcome to the next episode of ECIST Bitesize. My name is Helen Bennett. I'm a Senior Improvement Manager with the Emergency Care Improvement Support Team, and I'm really excited to welcome my good friend and colleague Tash Tuck. Tash, do you want to introduce yourself?
Yeah, of course. Thank you, Helen. My name's Natasha Tuck. I work for ESNEFT in Colchester Hospital, and my current role is an Interim Director of Nursing for Emergency Care and Medicine. So when we worked together previously, I was the Emergency Department matron, Helen.
Lovely, thanks Tash. So this afternoon what we're going to talk through is a question that we get asked quite a lot about the nurse in charge role in the emergency department, and I know you've worked on this throughout the times that we've worked together, so it's just really to get your view and your understanding. So Tash, let's go through why is the nurse in charge role so important?
Well, I mean, it's always been important, and it's nothing new. It's always a role that we've had. But I think looking back, what we noticed when I was in post, I've been a nurse in charge myself and in post as a matron, there was so many nurses in charge with different strengths, and there was no real clarity or consistency of what the expectations were of that role. It was really necessary to have that nurse in charge role, to have that helicopter view over the emergency department, to ensure that we were looking at the safety and risk of that department at the time with the patients involved. It was also vital to make sure that patients were seen in a timely manner, and especially if patients were referred to different specialities, to make sure those reviews happened so we could get some early decisions. Also within the emergency department and at Colchester, and probably in many, there's different silos. So you have your minors, your resus, your majors. So what it allowed was for that nurse in charge to have that oversight and check that the patients were all in the right relevant areas, and just to see how they were functioning, because you also have your band sixes in charge within each area too. So it created like a bit of a communication. What was also really important when we clarified the role was we ensured that there was really good governance throughout the day. So we created that nurse in charge log. So throughout the day they could record the situation, any issues that had happened, and it gave us a chance to then look back, pick issues up in real time, but also if there were any problems or stumbling blocks in the functioning of that department that day, we were able to go back and look and see how we could fix it for the future. The other thing the role really did was really clarify with the nurse in charge what escalations were necessary. So as you know, the ED functions in conjunction with the site team and the rest of the hospital. So what was really good to sit down and work out with the team is what was necessary to escalate and the best way to escalate, so it's factual rather than if ED gets really pressured and you feel a bit emotional and a bit stressed about the situation, it enabled you to work through it methodically and give factual escalations and ask what the response was going to be back to the individuals that you needed to escalate to.
That's really important, isn't it? That clarity of purpose and the expectations and laying that out. So, okay, so you talked about why. So let's talk through how. So how did you do this, and what was important to do, and who was important to be involved?
Yeah, so it didn't happen overnight. It took a bit of background work, and what was really important that the nurse in charge role wasn't developed in isolation. Because actually we work through the consultant in charge role at the same time, because it's really essential that relationship of that nurse in charge and consultant in charge role is developed and they work together to ensure that you can run an efficient and safe emergency department. The cohesive working, so the sitting down, the brainstorming, what should this standard operation procedure look like, what should the role look like, what kind of things is essential, what touch points needed to happen throughout the day. It was really important to involve the teams in those decisions, because then you've already got that buy-in, that they're actually on board, they're developing that role themselves. Obviously there's elements as a matron that I wanted to see in that SOP as well and that role, but it was really good brainstorming together with the consultant in charge. So it pointed everybody in the same direction. We all had the same vision for the emergency department. And what's interesting now since developing that is we use it a lot in our inductions, not only for when you're appointing new senior roles, but junior roles as well. So they understood how that nurse in charge and consultant in charge roles functioned. They had that support element and that go-to person. Because actually in times of pressure, which you have in an ED department, when it just feels a bit overwhelming sometimes, it was really important that people knew who to go to, staff knew who to approach, and what the function of that nurse in charge role is and was at that time. The other thing that was really important was actually me as my matron oversight, so that leadership and that visibility, not only for the consultant in charge and nurse in charge, for me too, because actually developing in it needed that support and that reassurance that we're doing the right thing. Because as I said earlier, we had so many different personalities, so many strengths that actually, you know, a lot of them weren't comfortable at doing certain things or escalating. So that visible leadership from myself and from the consultant in charge and nurse in charge were really key. Another thing we developed, so obviously developing these together, that cohesive working, it was really important to introduce a wake-up meeting. So we called it a morning wake-up meeting in ED, where the nurse in charge, consultant in charge, maybe one of the rota managers, sat down first thing in the morning. They looked at what the department looked like, what patients we had, what resus looked like, any issues from yesterday, any issues impending today, what the staffing looked like, and actually that's where we allocated our resources. So the nurse in charge would always know what doctors were placed in what areas, so they were the go-to people. You know, when you're doing that helicopter view and you've got a bit of pressure in ambulatory and not so much in majors, it's about moving your resources to cope with that demand. So those wake-up meetings were really, really useful, because the nurse in charge had also been to the bed meeting of that morning and could relay what the site and trust position was as well, which is really important for an ED department to know also the pressures externally as well as within their own department. So talking about how we introduced it and how it's developed, it's been really essential. It's provided a really good baseline, but it's been really essential with COVID. So actually there's additional touch points and things that the nurse in charge needs to do with infection control, to do with swabbing, to make sure that we had the right measures in place and no delays, because the timeliness of the swabbing has been essential during COVID. And obviously splitting your EDs into red and green, that nurse in charge role has been completely embedded and was ready to deal with this kind of situation and this oversight. So it's a proactive role, really. So that's what's been really good about it. Rather than you wait for that department to get overcrowded, you can see what's coming in from the ambulance. You're discussing with your Halo, your hospital liaison officer from the ambulance crew. You're thinking about the amount of patients that have been referred or look like they're coming in, and you've also got that you're in touch with the EAU coordinator as well. So yeah, it's been developed and will continue to be updated as things change.
So that, I mean, it sounds really, really good, and I think I'm sure you're on a different version to the ones that, you know, and you're right, these things do evolve and the situations take over, don't they? But what you've described is the safety for your teams around grounding them in times of an extremist position, which is really, really helpful, and it looks after the well-being of the team as well. But Tash, let's move on to talk to me about how you think this has improved patient experience as a result.
So I think it's made a huge difference, not only to patient experience, but also the safety of the patients in the department. Huge difference. So that joined up working, that sharing and joined oversight of departmental pressures with a nurse in charge and consultant in charge have been absolutely key. What it's also done is improved the teamwork, it's improved the communication and the clarity for the staff. What it's allowed for patient experience and safety is early escalation. So you're kind of like a bit of a temperature check yourself as to how that ED department's running or going and the expectations. So it's allowed early escalation. After we'd put this role into place, obviously we had the ambulance offload, standard procedures come in. So it helped us integrate how we worked that process. We brought in a safety nurse role for peak times. You know, they all happen like 5-6 p.m. till 2 a.m. in an emergency department. So all of these things were born off the back of this nurse in charge role, of actually how we needed to put safety aspects in. The nurse in charge and consultant in charge do safety walkarounds, which are, you know, that visible leadership, because actually you can speak to the patients, patient experience is improved, clinical prioritisation when you're busy and the capacity and demand is just feeling a bit pressured. But also for patient experience, you know, it's about spending the least amount of time in our department and getting under the right speciality, or being able to be discharged home, you know, back to where they really want to be. No one wants to be in an ED department, really. So another thing that we brought in were board rounds. So we run board rounds regularly within the department every 2 hours. If they need to be every hour because of the numbers and sheer volume in the department, or ad hoc, we'd run those board rounds, and it supported the junior team with decision making. And actually at times when there wasn't the pressure, sometimes an ED department doesn't have the pressure, you could utilise those board rounds as learning for presentations, which the nurse in charge was heavily involved in as well. So it brought on that cohesive working again. As far as patient experience, as I've said, it was really important that this was a visible leadership role. So it enabled that band 7, that nurse in charge, to go around the different areas within the department, obviously speaking to relatives, family, and being there as a support for them if they had any questions or worries. So that was really vital, and I think it's done a lot to keep the patients safe and the department, because you need communication also with the doctor and the nursing team. You don't want them to be in silos. Communication is so important in everything we do.
Gosh, thank you so much. I mean, it sounds as though some of the unintended consequences about your team work and the bringing together with all the people working across ED has really had a big impact for patients at Colchester. So thank you very much for your time. I could talk to you all afternoon, but for now, thanks very much.
No, it's been a pleasure. Thank you, Helen.